All right, we are live. We are live at our midday. Well, at least it's midday for me, our noon Eastern time VETgirl YouTube live webinar. We're talking about key clinical updates from Derm meetings. And we have Dr. Kwochka with us. Super excited because we all know Derm is so very important in practice. And I'm excited to hear what we have to say today. But if this is your first VETgirl YouTube live webinar, you're in for a treat. My name is Garrett Pachtinger. I'm a critical care specialist and the co-founder of VETgirl. I am logging in as I look out my window from my virtual window, my virtual background. I should look which way? This way. Logging in from sunny Pennsylvania. Dr. Kwochka, where are you logging in from?
Well, I'm also in a sunny environment. I'm from sunny Greenville, South Carolina.
Awesome. And many of you do know, and we love it for it to happen again. Type into your comment a little screener right there where you're logging in from. We love knowing where you're logging in from, whether it's North America or around the world. I see we have our friends from Portugal. Let's type that in because I want to see. And as you do that, I'm going to start with some of our VETgirl intro housekeeping information to get everybody in the know of what's going to happen today. First of all, a big thank you to Elanco for sponsoring today's event. You all know that when we have the benefit of partnering with an amazing educational associate like Elanco, we're happy to provide completely free race-approved CE to the veterinary world. So again, thank you so much to Elanco for being here with us today and allowing us to put on such an amazing event. With that said, I just said this is free race approved CE. So how are you going to get your race CE certificate? Well, one of two ways. You can either use yours. I take my phone out of my pocket, your fancy phone, and look at that QR code with your phone and fill out the form, or type into that little website address area, your HTML bar there, tinyurl.com/VG, VETgirl, VG, and then today's date, which is 11/30/23. We're going to leave this option open for 30 minutes after the end of the session. So this is a 12 to 12:30 Eastern session. That form will be open until 1 p.m. Eastern. I will go ahead and type that address into the question screener after I'm done with my introduction, so you can copy and paste it as well. Because we're doing this on YouTube Live, and YouTube, I know sometimes it's that small screen, but if you click on that open little box in your YouTube, you can make it the full size of your screen, which may be nicer to view. If you are a VETgirl member, you probably know about this, but just in case, for those that are not as well, we hope you're learning with VETgirl in the multiple ways we provide education. And one of the great ways is with our certificate programs to help you become more proficient in a specific area. So whether it's anesthesia, ophthalmology, ER, or any one of our currently 11 certificates, we hope you're taking part in those certificate programs because it's part of your VETgirl membership. If you're not a VETgirl member, try it out. For 14 days, you get access to watch any and all of our content. To get CE, you do need to be a full member on the platform. Now, this event is CE approved, so don't worry, you're going to get it for today. But for our other events, you get 14 days to watch. If you like it, we hope you join. And we do hope you know about it and are going to sign up for VETgirl U this year in June in amazing New Orleans. So you get some education, some beignets, some jazz band. It can't all be that bad, right? So make sure you sign up, and please do so before January 1st. Our early bird pricing is in effect until Jan 1st, and then the price goes up a little bit along the way. So check it out. You don't want to have FOMO. All right. I talk fast because I know you're not here to listen to me today. We're here to listen to Dr. Kwochka talk about Derm. So Dr. Kwochka, thank you again so much for being here. If you can give our audience a little bit of a background of who you are, what you love to do, and then please take it away. The floor is yours. And thanks again for being here with us today.
Yeah, Garrett, thank you. Thank you. It's great to be here. You need to send me some beignets from New Orleans. I love beignets and some of that good chicory coffee down there as well. So first of all, I'm looking at the chat and I see some friends, some people that I've known for many years. So thank you for joining. Thank everybody for actually joining. Very briefly about myself, obviously board certified dermatologist here in the United States. The first half of my career for 16 years, I was the head of dermatology at the veterinary college at the Ohio State University. And then I was in private practice in Southern California and in Charleston, South Carolina. And for the last almost 20 years now, I've been in industry with roles in R&D. And most of my time actually spent providing education around the country and around the world. And I'm also the past president of the World Association for Veterinary Dermatology and the American College of Veterinary Dermatology. So that's all you need to know about me so we can get into the presentation. And what I do here is I'm going to cover 4 recently published clinical studies that have been done that have direct application for what you do on a day in and day out basis in practice. And the way I do this, I'm going to pose, first of all, what the question was that the investigators had, and then we'll follow up and I'm going to say why they did it and what they did and what they found. And then in the conclusions, it will become obvious to you why this has clinical relevance. And I hope some of this information you can take back and use directly in your practice. So the first one here, the investigators asked the question, how effective is local treatment of canine anal sacculitis? And the reason why they did this is because, amazingly, for as common as anal sacculitis is, there's very little published on topical treatment. And when we define anal sacculitis, we're simply talking about what I have highlighted here, inflammation and infection. Now, certainly anal sac disease can progress and become more serious with abscesses and draining tracts and cellulitis, but that's not what we're talking about here. We're talking about what we see day in and day out in practice. Also, there have been several comorbidities that have been postulated to be associated with anal sacculitis, and so they looked at that as well. And another thing that they looked at, do you really need systemic antibiotics? Are they effective or are they really necessary for the treatment of anal sacculitis? So what they did is this was a retrospective study, and this was a diagnosis that was made clinically, just like you make it in practice day in and day out by dogs licking and chewing at the perianal area, scooting, sometimes blood in the stool, leakage, or other observations. What they did not include here were the advanced cases, if there were fistulas or masses, or if there were abscesses that had developed. What they did, they collected all the historical data from the records, from the cases before they were referred into them. And then they also looked back at their own records to see what they had done to treat these dogs topically. So it was what was used for topical and systemic medications. How did they flush them? What medications did they use for infusion? Number of treatments, interval between treatments, and then obviously the important one, what was the treatment outcome? What was the clinical resolution? So what they found was they had 33 dogs that were studied, equal gender distribution, 24 breeds, middle-aged dogs. None of these dogs, when they looked at the whole population here, the median, the mean, the population was not obese, because sometimes obesity has been associated with anal sac disease. Did not appear to be the case in this study. Antibiotics, and this is an important one here. Prior to referral, over 50% of the cases had received systemic antibiotics. And of those dogs, 50% had received multiple courses of multiple systemic antibiotics. And with these cases being referred, the antibiotics were obviously not working. And amazingly, in spite of the fact that over 50% of the dogs had received systemic antibiotics, less than a quarter of the dogs had any local topical treatment with flushing or infusion of the anal sacs. What they found was stool quality did not appear to play a major role in the development of anal sacculitis, because in 70% of these cases, the stool quality was normal. It was only abnormal in about 20%. And not surprisingly, when they looked at comorbidities, the number one was dogs that had atopic dermatitis. And certainly we see dogs that have pruritus ani and may develop anal sac disease associated with environmental allergens. We used to say that ears and rears were more specifically food allergy. And while some of these dogs can have food allergy, the majority of these dogs appear to have environmental allergies to pollens, so atopic dermatitis. That was the #1 comorbidity. 80% of these cases were bilateral. And here's the important thing. Here is the treatment regime used in the practice on these cases that were antibiotic failures and were referred in. They express the anal sacs in a normal way you would do it, lubricated gloved finger. Now they evaluated the contents cytologically to look for increase in white cells, to look for red cells, to look at whether there were bacteria present in that exudae. They flush the anal sacs out using a Tomcat catheter with a 6 ml syringe, flushing that sac with sterile saline until the contents came out clear. And then they infused these anal sacs with topical therapy. And the topical therapy that was used was either Mometamax or Entoderm, which is the generic for Animax. So these are combination products with a steroid, an antibiotic, and an antifungal agent. These treatments were repeated at 2-week intervals until there was clinical resolution, and the average number of treatments was 3. So 3 treatments with 14 days between treatment. And that might seem to you like a lot of treatments, but remember, these were difficult cases that were referred in as being failures at the general practitioner level. Now, some of these cases had so much perianal inflammation and dermatitis that that perianal area was also treated with Mometamax or Entoderm. And some had so much inflammation that glucocorticoids were used systemically, and that was found in 15% of the population. So here's what the important aspect of this. How effective was topical treatment alone without incorporating systemic antibiotics? And it was very effective, because if we combine the clinical resolution that was seen on re-examination and also the resolution that was reported by owners over the phone saying, I don't need to bring my dog back, my dog looks great, no problems here, that was pushing 85%. 3 dogs had recurrences. Many days after the treatment was stopped, they responded well to a second course of treatment. And one of those dogs had additional diagnostics and was found to have atopic dermatitis, which is what we already said was the #1 comorbidity. So if we look at conclusions and recommendations, local treatment, as described, was effective in about 85% of the cases. And these were cases that more than 50% had received systemic antibiotics without resolution. So the question is, do you really need systemic antibiotics for canine anal sacculitis, for the routine ones that you see coming in? And the answer to that question is probably no. Now, what they didn't look at in this study was if you use topical therapy and systemic antibiotics, would they have resolved quicker? And we don't know the answer to that question because that wasn't part of the study. Atopic dermatitis is the most frequent comorbidity. So if you have cases in your practice that have recurrent anal sacculitis, especially with other parts of the body maybe being involved, put that towards the top of your list of differentials. And it's only a small percentage of dogs that had poor stool quality. So some really good practical information coming out of this study for things that you see on a day in and day out basis in your practice. Now, this is a really practical one. The second study, the investigators said, what sampling technique has the best ability to recover the greatest number of staph organisms when you see dogs with superficial pyoderma? And the reason why they did this is, you all know we see a lot of superficial pyoderma, and it's generally due to staph pseudointermedius. Now, we don't recommend doing culture and susceptibility for most of these cases that come in with a first occurrence of a pyoderma, but if you've used empirical antibiotics that should work, and you still have a pyoderma and it hasn't responded, now you should consider doing culture and susceptibility to select the correct systemic antibiotic. And when we do culture and susceptibility, our goal is we want to recover the greatest number of bacteria that we possibly can, because that maximizes our chances for the micro lab being able to look at that plate and find some of those strains on that plate that might be the resistant ones, and go ahead and do susceptibility on those so that we identify resistance and we identify the correct systemic antibiotic. Now, most common lesions that we see, we know that a pustule is the primary lesion, but because those are fragile and transient, we usually find epidermal collarettes and crusts. So when we look at these dogs with a superficial pyoderma, you're seeing a good example here of several epidermal collarettes on a dog with superficial pyoderma. If we collect the sample cytologically, and we usually do it from that margin of the lesion where that epidermis is crusting and peeling back where we have erythema, that's where we're likely to find the bugs. And we look cytologically, we confirm the diagnosis by seeing the coccoid bacteria, and these usually occur in pairs or what we call diplococci. So what was done in this study is they took these epidermal collarettes and did an imaginary transection down the center, and they used sterile swab to roll over the lesions 4 times. And on one side, they used a sterile dry swab, and on the other side, a saline-soaked sterile swab. And what they did after they collected those samples by routine technique, they cultured these, incubated them for 24 hours, and then counted the number of staph organisms that they found, and they averaged those. And here's what they found, which was pretty impressive. They had 19 paired culture swabs, and there was a more than 100% increase in the number of bugs in the samples that were taken with the saline swab versus the dry swab. And if we look at the actual numbers, the median number using a dry swab was about 7,500 colony forming units per ml. But with the saline soak swab, it was over 30,000, a highly, highly significant difference that was found there. So the conclusion here is that if you use a saline soak swab, you're going to get higher numbers of bacteria compared to the dry method, and that would be preferred. Now, another option that you have, although we don't have data on this, but it's something that I've used over the years in practice, since I'm sending my sample in transport media, sometimes what I'll do is take that sterile swab, put it into the transport media, and moisten my swab with the transport media so it's moist, and then I'll go ahead and collect my samples. And it's often good to collect more than one epidermal collarette. Do 3 or 4 or 5 of them on the same swab. It doesn't cost any more to do that, and you might maximize your chances of finding resistant populations of bacteria, because what's in one lesion might not be in another lesion on another different part of the body. And then I'll put that in the transport media and I'll send it off to the lab. Again, no data on that, but I have found that to be a particularly effective way in my practice over the years. So conclusions and recommendations is collect that using a moistened swab. Now, what I will say, if you're going to soak swab in sterile saline, be sure that sterile saline doesn't have a preservative in it, because some saline can be preserved with benzyl alcohol as a preservative so that the saline doesn't get contaminated. You don't want to do that because the benzyl alcohol will kill bugs. So it has to be a non-preserved sterile saline sample. So if you do this and you increase your numbers, you're going to increase your chances of finding those subpopulations that might be resistant and decrease your chances of finding false negatives. The third one that we'll look at asks the question, does an initial 4-day course of prednisolone decrease the probability of having a pruritus rebound when you reduce the frequency of oclacitinib administration at day 14? And the reason why they did this, and you've observed this in your practices in some of your cases, and it's been documented in 3 randomized control trials. When you decrease that Apoquel dosage from twice a day to once a day after 2 weeks, some dogs will have an increase and a spike in their pruritic activity. to the point that some owners will be calling back and saying, my dog was doing great, and now it's not doing so well since I've gone to once a day treatment. How often does this occur? In the studies that have been done, in up to 45% of patients. And the other thing is, once you go to once a day, it spikes up. It tends to normalize or may go down a little over time, but never reaches the level that it did while that dog was on twice a day administration. And the theory here is that because the Apoquel, the oclacitinib, is not decreasing IL-31 production, which is the primary pro-pruritic cytokine, that stuff is all circulating around and is binding to receptors. So when you decrease the dosage in a drug that has a short half-life, you're no longer blocking the signal. So now the signal gets through that cell for inflammation and for pruritus. So the hypothesis here is if we use a little bit steroid early on, maybe we decrease IL-31 production and we can decrease the likelihood of this rebound occurring. So what they did, they had 40 dogs and they divided them into a group that just got the standard dose of Apoquel, or one that got the standard dose of Apoquel plus prednisolone at 0.5 milligram per kilogram twice a day for the first 4 days. No other drug. So the prednisolone just for the first 4 days, BID at 0.5 milligram per kilogram. And then what they evaluated, and I'm not going to go into all these in detail, the investigators looked at improvement in clinical signs, and that's done with the CADESI scoring system. But most importantly, the owners evaluated their dog's level of pruritus on the standard 10-point visual analog scale. And the primary outcome measure that they looked at was, what is the percentage of dogs that have a pruritus rebound on day 21 in comparison to day 14 for both of the treatment groups? And here's what they found. Now, first of all, I'm going to give you the summary of the data, but I wanted you to look at this. What you're seeing here is that vertical scale, the PVAS, that's the 10-point itch scale, with 10 being the worst and 0 being no itch. And you got oclacitinib monotherapy on the left, oclacitinib with prednisolone on the right. And these are all the dogs in the study. And the reason why I wanted to show you this, because even looking at these scatter plots of all the dogs, you can see much more consistency for the dogs that receive the oclacitinib and the prednisolone versus the monotherapy. You see a better, more consistent decrease in the pruritus scores over the first 4 to 14 days. And you also see a more consistent response from day 14 to 21 and day 28, with less dogs having an increase, a spike in their pruritus after that 14-day period of time. Now, if we summarize the data for these dogs that completed the study, both groups had similar itch baseline scores. Both groups experienced a really significant reduction in their pruritus scores during the trial, a really great drug for pruritus. But in the group that had the oclacitinib alone, 45% showed a rebound effect. Whereas in the combination group, only 15% of the dogs. So you had 30% of the dogs had a better response as far as decreasing the likelihood of a pruritus rebound by using those 4 days of prednisolone during the first 4 days of treatment. Now, not only did you have a decrease in the pruritus rebound effect, but the pruritus scores were significantly lower during the course of this study for the a group that had combination therapy versus monotherapy. The clinical scores, actually, more of them reached normal for the combination therapy versus the monotherapy. And the owner's overall evaluation of how well their dogs were doing was better for the combination group than it was for monotherapy with Apoquel. Now, there was some additional adverse events seen, perhaps associated with those first 4 days of prednisolone, because in the monotherapy group, only one dog had vomiting. 2 dogs with vomiting, 2 dogs with diarrhea, 1 with sleepiness, and 1 with PUPD. In the combination group, these adverse events were all considered to be minor and intermittent and resolve spontaneously. So not an ideal situation from seeing perhaps more clinical abnormalities associated with doing it. So those are the positive and the negative effects that one has to weigh. So in conclusion, 4 days of prednisolone led to not only a significant decrease in frequency of rebounds, but greater reduction in pruritus and clinical lesion scores. And the thought here is, as I said in the introductory slide, the glucocorticoids may be reducing the production of that IL-31, such that when you go from twice a day to once a day in your dosage of Apoquel, you're not getting as much of a rebound effect because there's not as much circulating IL-31 at that point. So the recommendation here is if you are seeing this in your practice, in a practice situation, by using that short course of glucocorticoids, you may decrease the risk of the pruritus rebound effect. The final study that we're going to talk about here is, can the administration of ATOP7 spot-on and hydrospray increase the interval between Cytopoint injections to maintain a dog's comfort level with atopic dermatitis? And the reason why they did it, we know that Cytopoint is a fabulous biologic for treating dogs with canine atopic dermatitis. It's approved for use every 4 to 8 weeks, but it can be expensive, especially in larger breeds. We also know that topical therapy is indicated in dogs with atopic dermatitis because they have that defective barrier that lets allergens in that leads to the allergic reaction. And by regular support of that defective barrier with topical therapy, there are some studies that suggest we may be able to use lower doses of our systemic therapy if we go ahead and do that. And so just to review for you here, dogs that have atopic dermatitis have an abnormal skin barrier. They don't have enough lipids or the right type of lipids in that stratum corneum barrier, so it becomes all disorganized, and that allows environmental allergens and bacterial and fungal pathogens to get in, which makes the clinical disease worse. So what was done in this study, they took a population of dogs with atopic dermatitis that were treated with Cytopoint. And they knew how often these dogs needed their Cytopoint injections because they were stable for 5 consecutive treatment intervals. And then they added in ATOP7 spot-on a weekly basis. And twice weekly on the affected areas, they were treated with ATOP7 spray. Now, the reason why they wanted to do this regime instead of using like shampoos and rinses, they wanted to do something that was as easy topically as a client might want to do. And there's also some good published data showing that ATOP7, which basically is naturally derived plant oils that are high in fatty acids, there's some data showing that they can actually improve that defective barrier. So after starting the dogs on treatment, then they monitored these dogs for 5 more visits, and the owners were instructed to come back in when clinical signs started to return for their next injection so they could determine what the interval was since the last injection, and then how itchy are the dogs, what is their CAD lesion index, and then because they're applying a topical, what does the skin and the hair coat look like cosmetically? And what they found on this, and this is a pilot study because it doesn't have a lot of dogs in it, and these studies are difficult to do because this study goes for essentially a year, and it's hard to keep a lot of dogs on a study for that period of time. So this is some interesting pilot data. But what they found was at the start of the study, these dogs needed their Cytopoint injections every 31 days. But by the end of the study, that could be stretched out by almost 2 weeks. They required their Cytopoint injection less frequently, a greater interval, therefore saving the owners some money. And in spite of using the Cytopoint less frequently with a longer interval, their pruritus scores actually improved more by 26%. Their clinical lesion scores improved by 31%, and their cosmetic scores actually improved by 25%. So not only could you give the injections less frequently, but actually the patients were doing better with their important parameters. So the conclusions here suggest that if you do effective topical therapy, and in this case with something that is not that difficult for the owners to do compared to frequent shampoos and rinses on a regular basis, you may have a sparing effect on the frequency of application of your systemic therapy, and at the same time reduce the clinical lesions. Now, obviously, anytime we do topical therapy, client compliance is essential to success, and essentially more additional studies would be nice with a larger population of patients. So when we go through this, that now concludes a quick run through on 4 recent clinically relevant studies that have been done that hopefully have application to some of the things that you do in a clinical practice situation on a really regular basis. And I hope that you at least have 2 or 3 things that you can take back to your practice and consider for use immediately, either diagnostic or therapeutically. Thank you so much.
Dr. Kwochka, that was awesome information. I loved as you just said, it was so clinically applicable that to me, it's impossible not to bring something back to your clinic with all those good studies and all those great reviews. And so thank you so much. And again, I wanted to give a big shout out to Elanco, to their generous support that we're able to provide this race approved event free to that veterinary world. As a reminder, how to get your CE. I typed it into the little screener, the comment screener a couple of times, but either use your fancy smartphone and use that QR code, and/or in your web browser, type in that web address, tinyurl.com/VG, and then today's date, which is 11/30/23. Please fill out that form. That will be available for about the next 29 minutes or so. We'll close it down at 1 p.m. Eastern. So please make sure to do that. Please also make sure when you fill out that form, you use the email address associated with your VETgirl account. Most of you know that automatically now, as soon as we get that form filled out, we will put that CE certificate in your VETgirl account for safekeeping, so you always know where it is going to be. With that said, I would love to get to a couple of questions. Please, we'll try to get to as many as possible, maybe 3 or 4 if we can, time dependent. Go ahead and type them in. When we're talking about that study using glucocorticoids, Dr. Kwochka, I believe you said, I just want to confirm, and maybe I'll pull back that slide as well. The dose of glucocorticoids that you use, I'm going to pull that back up, is 0.5 milligram per kilogram twice a day for 4 days, correct?
That is correct.
Okay, excellent. Yep. And I'll say this out loud just so everyone understands, and you agree or disagree, but small dose, no need to wean off of that. It's obviously something we don't expect a lot of side effects. It's not that immunosuppressive high end that we have in our immunosuppressive diseases like ITP or IMHA. So hopefully a nice dose, and as you showed, a little bit of side effect, but certainly not the ones we see from those high dose dogs.
Exactly. Yeah. No need to wean off. That's a common question. And yeah, absolutely. It's a low anti-inflammatory dose for a short period of time. Absolutely.
Perfect. Going back to your first case, the report that we talked about, or journal article about the fistulas, the perianal fistulas. Do you know if those dogs were sedated for any of those procedures, or were they awake?
Yeah, undoubtedly they were, because if you're talking about dogs that have discomfort and you're putting a catheter up there and doing multiple flushings, they didn't necessarily report on every case in sedation, but certainly for a procedure like that, probably what would be most commonly used would be something like butorphanol, or butorphanol along with dexmedetomidine would be indicated. I think it would be the rare case that would probably tolerate those type of procedures. And it may be a situation where if you're going to flush them a couple times at a 2-week interval, the first time they may need the sedation, perhaps less of a dosage when you have some of the pain under control when you see them back for the second application if it's needed.
And I know during that study you commented that the cases that were the more severe, the ones that actually had the draining tracts or masses or other things were ruled out. Do you think this is a very representative population of what general practitioners could see? Meaning we've ruled out, and not ruled out, probably not the right phrase, but we've eliminated maybe some of those really bad referral cases that may get to the dermatologist that could have skewed the study results. So you feel this is a fairly representative population for general practitioners?
Absolutely. And I think that's why the investigators, to their credit, did it that way, because they know if you get those more advanced one, then you're doing more diagnostics. I mean, if you have a mass there, then you're going to want to get cytology of those by doing a fine needle aspirate to determine what's going on. So there's additional diagnostics. What they wanted to look at were the routine cases that all of the folks out there are seeing on a day in and day out basis.
Perfect. Thank you. And
Yep.
reverting back to our steroid question from before, that was that steroid dose started at the start of the Apoquel,
Yes.
or was that it? So to confirm, not, let's say we're stopping the Apoquel at 14, then we start the steroid. This was, we're going to start Apoquel and prednisolone at the same time, day one, for 4 days.
Yes, absolutely.
Perfect.
Yep, they were started at the same time for a 4-day period. And that's another question we get. You're using 2 potentially immunosuppressive agents. Are you concerned about that? And the answer is no. It's 4 days and it's a low dose. So it's not uncommon that even when we're treating dogs over a long period of time with something like Apoquel or something like Cytopoint, and we have a dog that has a flare, for example, during the worst part of their allergy season, say in the spring when the trees are pollinating, that we'll use a short course of steroids during that period of time to bring them back under control. So no worry for that short a period of time and that low of a dosage.
Perfect. And we'll finish up with one final question
Mhm.
here. To me, this is one of those very common questions. You probably get it all the time, I'd like to think, but the question is about omega-3 supplementation, omega fatty acid supplementation. What's your opinion on that? And the specific question actually related to the help of decreasing dosing, let's say of Cytopoint or other drugs. Do you find that as helpful, and or could it be possible to do that as well?
Yeah, absolutely, we do. And what I would say, and there's publications. I mean, there's at least a half a dozen publications that have dealt with using omega-3 fatty acids primarily at appropriate dosages, demonstrating a sparing effect on the dosage, and that has been seen with glucocorticoids. That has been seen with cyclosporin, so atopica. That has been seen more recently with Apoquel, that you can significantly decrease the dosage if you have the right omega-3 fatty acid at the right dosage. So to give you an example, what is the right dosage? Well, when you're using a supplement or you're using a diet, you really want it to be fish oil based omega-3, because that's when you get the highest levels of DHA and EPA, which are the important in that chain, metabolic chain. Those are the important ones that have the anti-inflammatory activity. So you need to look at the label of your diet or your supplement and look how much EPA and DHA it has in it. Your target should be somewhere around 60 to 100 or more is okay, milligrams per kilogram per day of combined EPA and DHA. That is your target dosage that you want. If you're using a product that it doesn't list that, you probably shouldn't use that product because there's no way to actually figure the dosage. That's the dosage that has been used in these studies that has been demonstrated to be effective. If you simply follow the recommended label dose on your product, 90% of veterinary omega-3s are mislabeled because there's no efficacy requirement. So if you follow the dosage 90% of the time, you're way too low. The doses are not correct. If you get that dosage range, that's when you're going to see a medication sparing effect. And the most recent study that was done in Europe demonstrated that over a period of about 12 weeks, using an appropriate level of omega-3s, you could decrease your Apoquel dose from the 0.5 mg per kg per day down to 0.2 to 0.3 mg per kg per day and maintain those dogs at the same level of comfort or better comfort. So the more information we get, the more we seem to have positive results for omega-3 fatty acids, especially as far as being able to lower the dosage. So the bottom line there is when we're looking for multimodal therapy, when our patients aren't doing as well as we would like and we want to get more treatment in to our treatment, the two things that I would say most dermatologists, I wouldn't say all, but most dermatologists have to have at the top of their list for incorporating multimodal therapy, if the owners can do it, is an omega-3 fatty acid supplement and topical therapy. And then, of course, the other thing that's important, we always recommend, and people kind of forget this with the new drugs we have, still the best form of long-term treatment that actually alters the pathogenesis of the disease and is quite effective is to have a dog allergy tested and put on allergen-specific immunotherapy. We often forget about that because we have such great new pharmacologic agents and biologics that are out there. But still, because a dog develops their disease when they're 1 to 3 years of age and they're going to have it for the rest of their life, we're trying to minimize the amount of drugs we have to give that dog. And the one best thing that can actually do that is by getting the dog allergy tested and on allergen-specific immunotherapy. And a recent study there showed that if you have dog, and this was a study with over 600 dogs, it's the best immunotherapy study we have right now, followed these dogs out for a 9-month period of time, over 600 dogs that were on treatment and followed along with frequent rechecks, efficacy was 70%. So immunotherapy, although initially it takes a little while to have an effect and we do other things along with it while we're waiting for it to have an effect, that is probably still the best long-term thing we can actually do for our patients.
Awesome. Well, thank you for taking us down that little Omega trip. It was a little extra pearl of wisdom that I love. But again, thank you so much. Super clinically relevant, super practical. Thank you. Thank Elanco. Thank you all for being here today. I know we say this often that veterinary professionals work hard. Lunch breaks are non-existent. Maybe a granola bar here and there, and sometimes there's not a lot of thanks to be shared. So we're here to say thank you for all that you do each and every day. Thank you for taking care of those amazing patients. And thank you for being here with us today on this event. Please thank Elanco and Dr. Kwochka. Thank you so much for being here. We hope everyone has a great rest of your day, a great week, weekend, and holiday season. And with that, we'll see you hopefully at VETgirl U in New Orleans. If not, we'll see you online at our next VETgirl event. Have a great day, everyone. Thank you so much.
Bye-bye.